Good evening, everybody, and welcome to tonight's EEL webinar. Tonight we'll be talking about endometriosis diagnostic, and the question would be if we should modify the diagnostic algorithm for endometriosis with miRNA salivary signature. Tonight's EEL webinar is EEL's president, Dr. Harald Krentel, and our invited guest is Dr. Sofiane Bendifallah from Paris, France. Before we start, as always, we'll be recording this webinar and we'll be posting it on our social media and our website and YouTube channel. So by agreeing to continue watching our webinar, you agree with the recording and making it public. We'd like to thank our sponsor, Moderator. Okay, Harald, Sofiane, you have the floor.
Thank you, Alin Constantine, for your kind introduction. Yes, I'm very happy to present Professor Sofiane Bendifallah from Sorbonne University in Paris tonight, talking about a very important and very excellent topic, the use of a salivary test in order to diagnose the disease endometriosis. And I heard a lecture about this topic by your colleague, dear Professor Bendifallah, Professor Decon, and that was a lecture in Lisbon in the ESG Congress. And it was really excellent to see the science behind this test. So if you just listen, okay, this is a new test, then it seems simple and easy. But when you see what is behind it and what kind of science is used, that we talk about miRNA, which is more or less a comparable process to the finding of the vaccines in the pandemic situation. So this is really interesting, and it seems that this opens new horizons to our type of diagnosing patients, and it's really a pleasure to have you here. Thank you very much for your time. You all know Professor Bendifallah. As I said, he's from Sorbonne University. He's professor of gynecology and obstetrics, and he's specialized in gynecological surgery, especially in oncologic procedures and deep infiltrating endometriosis. And in his career, he focused on precision medicine. And now this is one of the results of your work that you present tonight. And to date, you published more than 250 papers, which is a huge number of scientific work. So for us, it's an honor, and we are very interested in getting information on your work, on the new test. It's already on the market. This is important to say, and I think it will start in Germany in these days, or it already started, yes, the beginning of October. So this is interesting for us. It's interesting for the patients, and of course we need information too, because then we can counsel our patients if they ask us. So thank you very much for having time for us tonight.
Thank you very much. I hope you hear me, and I'm very happy to be here this evening with you. And before to start, I would like warmly to thank you, Harald, to give me this opportunity to talk with my colleagues about the salivary miRNA signature. And the title of this presentation is deliberately provocative, and I would like to talk about how and why should we modify the diagnosis algorithm of endometriosis. And I hope this presentation will help us to bridge discussion and to discuss how to improve the healthcare thanks to this salivary signature. And we will discuss about the microRNA signature. And to deal about that, I just want to add this information. 98% is the rate of diagnostic accuracy to the salivary signature. And this rate must be made in confrontation to this delay. The delay of diagnosis in France, but it is the same whatever the country, whatever the healthcare system, it's between 7 and 20 years old. And as you know, the delay of diagnosis is probably one of the most important issues for patients, but also for colleagues. And as you know, this delay is also associated to another rate, 25%. And this rate is the rate of laparoscopy needed to perform the diagnosis. And when we discuss the accuracy of the salivary endotest, we need to discuss the technology, but also to discuss why we must discuss its role. And as you know, the diagnosis of endometriosis is associated for patients with bad experience. And when we look the data about this, we know all that the women to have a diagnosis need to visit specialized doctors more than 5 to 10 times. And this is really important because if we want to achieve to a confidence with our patient, we need to reduce this rate. And as you know, guidelines about endometriosis and about endometriosis diagnosis all are focused on this issue. And this is why the discussion is open. And as you know, I propose tonight, this evening, to discuss why we should modify the algorithm, how can we modify the algorithm, also the impact expected from the salivary test, and after that, we'll conclude by the level of evidence. And because the level of evidence is one of the part of the improvement of care, I will insist about that. Why? Because the endotest answer to one issue, which is the diagnostic screening. And as you know, for patient, but also for colleagues, the question and the issue of diagnosis is probably one of the most important topic concerning the healthcare for endometriosis. Why? Because as you know, currently the diagnostic tools for endometriosis are especially focused on questionnaire, MRI, and surgery. And when we focus on MRI and surgery, everyone knows this rate. Both fail to be over than a sensitivity of 95%, and both fail to be over a specificity of 90%. And as you know, these rates are really important because the Cochrane review from Nisenblatt say if you are able to be over than those both rates, you can replace the laparoscopy by an endotest. When we be inside of the rate of each tool, and when we focused on the imaging for endometriosis diagnosis, you know that for ovarian, the sonography, but also the MRI are very, very accurate to diagnose endometriosis. That's why the complexity and the discrepancy, which is necessary to explain to patient, is low. But as you know, for deep endometriosis, but also for superficial endometriosis, we have two main issues. First one, the complexity, which is not so easy for deep endometriosis, and for superficial endometriosis is very high. But there is another topic, which is the discrepancy between the imaging and the result, between the symptom of the patient and the information. And as you know, this discrepancy between the accuracy of each exam, the prevalence of the disease, which is probably very high for superficial lesion, explain why we have a high number of patients who need to wait maybe 5, 6, or 10 years to have a diagnosis. And at least when we focus on European guidelines, currently, imaging, ultrasonography, or MRI are the cornerstone of the diagnosis, and all the diagnosis is based on. And of course, these exams are accurate, but we have some limitation to improve the diagnosis. And when we analyze recommendation of Yeshro, we know that even when we perform sonography and MRI, and even when the diagnosis is the imaging are normal, we could not exclude endometriosis. And this conclusion is also the same when we offer laparoscopy and when we don't found endometriosis lesion, or sometimes we found lesion, but with pathology we don't have diagnosed, we could not consider that the endometriosis is made. That explains why it's so difficult for many patients to have this diagnosed. And this issue is similar for teenage women. And as you can see, the guidelines recommend for women, young women, if imaging are negative, and if medical treatment is not successful, to perform laparoscopy. And we can discuss this issue because for me, this is a major issue for young women. And as you know, we know all that the delay of diagnosis is associated for those patients with wandering, with suffering, with many investigations, and also with discrepancy between the imaging and the information that we have to give her. And that explains why the confidence between our patient and the care pathway and the care plan to improve their disease is so difficult for those patients. This is the context of the test. And as you know, now we have to discuss how. How it probably the most important innovation in gynecology since several years. We associated for the salivary microRNA signature two technologies. The first one, we use intelligence artificielle, and we associated to the intelligence artificielle several microRNA. And the combination of those two technologies help us to design the diagnosis. How? First, how to explain the role of intelligence artificielle. It's really easy to understand that if you use your phone and if you use your face recognition, it will be very easy for your phone to recognize you because you help him by several points of recognition. And those several points of recognition are the key of the recognition. This is probably the same for endometriosis because in this setting, we use microRNA. And as you know, the microRNA came from the transcriptome. And as you know, the transcriptome is a non-coding RNA. And this part is huge in all fluid of the human. You can find RNA in the blood. You can find RNA in the peritoneal liquids. You can find RNA in the saliva. And also, you can find RNA in other liquids. And those non-coding RNA can be shared by two topics, small non-coding RNA and long non-coding RNA. And in this issue of diagnosis, we focus especially on those microRNA. Why? Because the majority of publications on this topic have been published, especially focusing on those microRNA. But if you will have time, we can discuss about this subject because now we have more and more data about the potential of other RNA, long and small, to help us to improve the care pathway. And this is very interesting because for humans, before our work, it has been demonstrated that those microRNA are really important to help the DNA to be used for human. Why? Because the microRNA help the DNA to be regulated. And if the microRNA have a role in the regulation of the DNA, we will probably have or not have protein. And if you have up and down regulation of those microRNA, we can believe that the protein came or not came. And this is really important because when we look what happens in several diseases, especially for cancer, for neurological disease, and for autoimmune disease, we know that those microRNA have been associated with several physiopathological pathways. For example, for proliferation, for anti-apoptosis, for invasion, for metabolism. And as you know, the mechanism of endometriosis and the pathophysiology of endometriosis is associated with those pathways. Similarly, in cancer, as you know, it has been demonstrated before 2022 that few number of microRNA, not more than 200, especially in the blood of the menstruation, are associated with angiogenesis, inflammation, proliferation. And this is really important because this is what we know before our study. When we read this wonderful paper from Monaca, this paper is a review from all microRNA published in the literature since 10 years, especially all microRNA published in all fluids for human and focused on endometriosis. And the conclusion of this paper is none of the paper investigated microRNA in saliva. And at the moment, no scientifically proven salivary biomarker for endometriosis has been published. That explains why we focused on this topic, and this explains why we focused on the saliva. We perform microRNA sequencing by the sequencing of all microRNA for human space. Currently, more than 2,600 microRNA have been described. And we, for the first time in publication for endometriosis, we have made the association between all those microRNA and endometriosis diagnosis, if one is associated with diagnosis or not. And we especially focused on one topic, which is the performance, which is how we improve the accuracy of the diagnostic. And as you know, before our publication, it has been reported several studies on microRNA and endometriosis, but with a lack of two issues. First, nobody focused on all microRNA. And second issue, nobody worked with intelligence artificial to deal with all those biomarkers, which are very interesting because they focused on all points of description of patient. This first work, what we published, this is just the first study. We focused on the blood and we discussed the possibility, the ability to define microRNA in the blood and to found a diagnostic. And we did it. We have this sensitivity and this specificity. And because we made the comparison between blood and saliva, this is the most important discovery in our work. We discovered that the saliva is more accurate than the blood. And before this publication, nobody knew that. This is the second publication about the salivary microRNA signature. And as you can see, the sensitivity and specificity of this signature appear very high. Why? Probably because when we made the sequencing for all patients, you have here the photography of the sequencing for all patients, the 200 patients of this publication. And as you can see in green, you have the level of expression for each patient of microRNA. And in blue, the level of expression of all RNA. And for those patients, 200 women, we deal with the 2,600 microRNA, and we design a signature to diagnose endometriosis with a sensitivity about 96% and a specificity of 100%. In this study, we focused the inclusion criteria on women with and without endometriosis. For women with endometriosis, we focus on early stage and on late stage. For women without endometriosis, we focused, of course, for women who had the same symptom as endometriosis, but at least no endometriosis after laparoscopy confirmation and after pathological confirmation. Of course, the issue of the blood and the saliva is very interesting because when we made the comparison between the accuracy of both signature, we can say, okay, the microRNA, all microRNA associated with artificial intelligence help us to make the diagnosis. But what we can see in the saliva, we have 5 characteristics very interesting. First, the saliva is very easy to collect. Second, as you know, it is non-invasive procedure. Of course, the safety is really important. The stability of microRNA expression, it can be discussed, is really the major point to have the stability of the signature and the time. And the reproducibility is also another characteristic of the saliva that it can be discussed maybe at the last. And as you can see, maybe I just want to show you the first. This is what we know before our work. This is how endometriosis can be designed thanks to a few number of microRNA. This is how today we can design for one patient, thanks to all microRNA, the physiopathological pathway to describe for one patient all microRNA associated to her disease. And as you know, endometriosis is a complex disease. Complex because we have many physiopathological pathways which can be included to explain the disease, the evolution, probably the answer to the treatment, and probably the symptom. And thanks to this publication, we focused on the major microRNA associated with the major physiopathological pathway for one woman. And the major important thing is, with this approach, the complexity of the disease can be designed. Of course, we focused on the diagnosis, but as you can understand, thanks to 2,600 factor biomarker characteristic, we can approach many issues for endometriosis. We deal with the diagnosis, we deal with the physiopathological pathway, we can deal with other issues. For example, recently we published this paper which focused especially on the phenotype of infertile women. And we found, as several previous authors, that few microRNA can help us to design the fertility signature. And this is really interesting because, as you can understand, if you have few microRNA to design the fertility, if you have few microRNA which can help to design the diagnosis, probably the future can be how to design the other phenotype of the disease thanks to few microRNA and other non-coding RNA. And for the oncologist people around this Zoom meeting, everyone know, for example, for endometrial cancer, 20 years ago, endometrial cancer was type 1 and type 2. And now we have a molecular classification. This is the way for us to improve endometriosis knowledge and comprehension. Of course, as I told you previously, to be confident about the technology of microRNA and the accuracy on the test, we need some proof. And of course, the level of evidence has to be improved. How? First, because the first study we published 6 papers focused especially on the EA model, and after on the blood and the saliva signature, and also on the technology and how we can make the sequencing. And now we focused slowly by slowly on the physiopathology, and after that on the phenotype on infertility, and we have other paper on this way. The second way, we launched 1 year ago a study. This is a multi-center validation study about 1,000 women, and we will finish this study in few days. I hope few next day, and we include 1,000 women with and without endometriosis to make the validation. And because we need an interim analysis, we perform the interim analysis, and this paper is now in submission, and we are waiting the reviewer about that. And the result of the external multi-center validation study are similar to the first study. And this is probably the most important thing to know about the validation. The third way to improve the level of evidence is the cost of the endotest, of the microRNA signature, and the cost in the care pathway. And this work is also actually in publication, and we use the care pathway designed by the Haute Autorité de Santé. This is French healthcare public authorities, and we use the endotest inside of the care pathway. And this care pathway is similar to European pathway. And we made an estimation, an assessment of the impact of endotest in this pathway. And we compare all these care pathway, including imaging, imaging plus endotest, or endotest alone. And it seems that the endotest, whatever the price, is probably the most cost-effective test to improve the care pathway of those women. Now, if I have a few minutes to make hypotheses about the impact of endotest, I can suggest you 4 ways. If collectively we improve the diagnosis because it will be more easy to do it, more sure to do it, we will say, okay, the diagnosis is not an issue for us now. We can now focus on pain, on quality of life, and on how to improve the care pathway. And probably for patients, it will be the most important thing in the future. We also can imagine, because the salivary microRNA signature had sensitivity and specificity over than 94% and 79%, and because this rate are the rate to replace surgery by a test, we can imagine now for the future, laparoscopy will not be so easy to perform, and we can replace it by the endotest. For fertility and early diagnosis, we can expect that if we reduce the rate of diagnostic surgery, probably we can expect it to reduce the fertility impact. And after that, we have to discuss the issue of fertility preservation. And as you know, because it can be designed to diagnose very early, because we can design some microRNA associated with fertility and infertility, we can make the hypothesis that improving this delay will improve the way to improve the fertility preservation for those women. This is our hypothesis, and I will be very happy to discuss those with you. The major limitation of our work is very easy. This is the main limitation that we have to discuss with my colleagues when we talk about the endotest. First, the sample size. Second, the validation and the external multi-center validation. Third, the reproducibility of the endotest, and also its characteristic of non-invasivity. And I will probably let this point for the discussion, but of course, we are focused on all these points to improve the accuracy and also to improve the level of evidence about this point. To conclude, and as Harald say it as an introduction, you know that since now 5 or 6 years, we have the COVID crisis, and we know that the vaccine is based on RNA. And also we know, especially for cancer, some authors are now performing clinical trials associating microRNA and potential therapeutic molecules in cancer. And probably if we be a little optimistic, we can say that if we have the ability to design the phenotype of a woman, thanks to more than 2,000 of characteristics, probably one day we will be able to find one or other potential therapeutic molecules for endometriosis. This is a hope. If I can conclude, this salivary sample is simple, is probably reliable. The reproducibility is now known because we have data about that, and it is the most important thing for us. It is non-invasive test. And of course, you understand, it is powerful of accuracy. Thank you very much for your kind attention.
Thank you very much for your excellent presentation. Yeah, I think this is really brilliant, but it also raises a lot of questions, of course. And I am a bit surprised because there's not a single question in the chat so far. Now it starts. That's good. So maybe I can start, and you let some points open and you said, okay, we can discuss it. So what would you say now to possible endometriosis patients? Would you say, okay, the first step that you do when there is a suspicion of endometriosis, you do the test, and then what's next? And I would like to combine this question with the idea, is it just black and white, or do you think that in the future a test can also divide a bit between severity, or if you combine it with symptoms? So what is your vision in this point?
Thank you. This is a really important and very interesting question. First of all, I can say that if you read the whole paper from Vanier, this is a Belgium team, they write that they are able to find some microRNA associated with the stage. They say, okay, few microRNA. And because those publications exist, we are already able to do the same. And of course, one day, I hope, soon, I hope, we will be able to say we will have or not endometriosis, and probably we have to design how to explain this is several disease or this is early stage. And we have now to think how to design this. And as you say it, because you understand the technology, of course, one day we'll want to know, and this is one of our next topic, because we are soon to launch study about that, if microRNA may help us to follow the treatment, to follow the answer of the treatment, and probably to make the correlation between microRNA, the status and the phenotype, and how the patient will follow his disease and will have evolution or not of her disease. But for the moment, it is just idea.
Okay, now we have some questions in the chat, and I will just go through the questions. So the first question is about the use of the artificial intelligence in your work. So the question is if you use some training model, or how was AI able to select the RNA? So I think that's where the question goes.
The models are, we use models to first to select the microRNA based on the population of women on the first study, and this population was divided on the development population and validation. And for validation, we use, and it was written in the both publication, a set of patients who are not used to develop the models. That explain why and the models was developed and validated on data which are not used to develop the models. Since the first publication, and because the third question is associated to the first one, we have the data of the 1,000 study. This is a validation study. And as I told you, we already have the data of the interim analysis. And we perform the validation, the external validation on multicentric data of the salivary signature on independent data, and we had the same result.
Thank you. Then there's a comment and a question about bringing this test to the market at this stage. So the question is it responsible to bring the test to the market with small subjects in the studies, and shouldn't there be more replications and validation in other cohorts?
What I can answer to this issue, of course, when we think about the powerful and the sample size, if we use classical statistical models, of course, made in the market test with only 200 patients is not responsible. But you have to think that for those studies, we use over than 2,600 characteristics per person. If you read the literature about endometriosis, if you found a study with many number of characteristics to define a patient with endometriosis, I will be happy to read it. That explains why, for us, when you have 200 patients, it is a good and enough number to say, okay, the models is enough accurate. Maybe I can just share with you this slide because, of course, this is the main issue that I can just show you this thing. When we read the literature about the sample size for classification, and when we read the classification sample size for intelligence artificial, we have two conclusions. First, there is no enough data to be and to have a consensus, and the artificial intelligence is not classical statistical models, for example, regression logistic or a KIDE. And this is the area under the curve associated with the number of patients and the rate of diagnosis associated. And as you can see, for artificial intelligence model, when you have more than 2,600 characteristics per person, you can see that the threshold, the optimal threshold where the model is enough trained and enough accurate is probably more than 100 patients. And this is really concordant with other publications in oncological field. We have some similar data, not our, but other author, which shows that when you have more than 100 patients and when you have more than 100 microRNA or characteristic using intelligence artificial, you have the optimal threshold to say this is accurate.
Thank you. Well, I just try to imagine how this will work in the next weeks and months in Germany. So I think for the patients, it will be very interesting to think about doing the test. Although it's quite a lot of money, of course, but the chance to maybe know if there's endometriosis or not, I think this is a very interesting possibility for the patient. So if they do the test and then they have the result, they will go to their gynecologist and they will say, hey, look, this is my test result. I have endometriosis. Please treat me. And what do you think is going to happen then? And how should we prepare on that scenario?
I think this is not the good scenario, because in our way to develop the salivary signature, we say, okay, the patient, it is at the center, but the patient need to see her doctor first to have the prescription of the endo test. And the patient can't buy the test alone and see her doctor with the test, I have it or I don't have it. That's why we are focused on the doctor, we are focused on the physician, we are focused on the nurse to say, okay, we are at the center of the prescription. And that means this scenario normally can't happen. And of course, because we have this remark previously, okay, we made the diagnosis, but we don't have any treatment. What we do now? Okay, we don't have any treatment. Now we have to find the treatment. We found an answer to the diagnosis. Now, collectively, we have to find a treatment for endometriosis. This is probably the next step.
Yes, that's true. And what would you recommend in order to describe the severity of the disease? So if the result is positive, then of course the question will be raised, okay, do we talk about deep endometriosis? Do we talk about peritoneal disease? And where is the place, in your opinion, for ultrasound, for MRI, or even laparoscopy?
For me, the place of in French design, the place on the test is in parallel or just after ultrasonography, because we know all that ultrasound is able to make the diagnosis of cyst, is able to make the diagnosis of deep endometriosis. But if the ultrasound can't give a diagnosis, and if you have a woman with symptoms, it will be very interesting to use the test at this moment. In my opinion, the test is not made to replace MRI, which is used in our country to make the cartography, to make the diagnosis. It's just used to say, okay, you have, you don't have, and after the imaging is here to make the cartography, to say the severity, and to help the clinician or the surgeon to care surgery or not, or to treat.
Okay, so I will go back to the chat, and there's a question from Cynthia, and she asked about how many patients with severe endo have been included to the 1,000 patients study. And with severe, in this case, the colleague is talking about RSRM stage 3 and 4.
Okay.
And is this relevant?
I will give you this answer, but we have just to focus all of us about the limitation of the RSRM to really describe what is severe endometriosis. I will give you my opinion what is severe endometriosis. Severe endometriosis is colorectal endometriosis, pelvic wall endometriosis, parametrial endometriosis. This is severe. And as you know, in RSRM, you will have severe if you have big cyst, which is not severe. This is my opinion. Now I will answer you because we use the RSRM in the study. I can give you the rate of severe cases in the interim analysis because I can't give you the data of the 1,000. In the interim analysis, we use the first 100 patients of the 1,000 study. In the 200 patients of the validation in the interim analysis, we have half of patients with severe cases, say, namely stage 3 and 4.
Mm-hmm. Okay, Alin asked the question if the test also covers adenomyosis. And there's another question which also goes to the same direction. And Lone is asking about the different types of endometriosis. So I think this is very interesting because we know that we have different types of activity and we talk about endometriosis, but maybe this does not mean that we always same thing. What is your idea on that detail? And I think you will have an answer because if we can find out about these phenotype details, then like that.
First, about the adenomyosis, this is really a very complex question for microRNA and also for endometriosis. Because if from a methodological point of view, want to make the perfect study to design a signature able to diagnose adenomyosis for women with dysmenorrhea and pelvic pain, we need to perform surgery and to remove the uterus in order to make pathological exam to really know if it is adenomyosis, internal, external, focus, and deep endometriosis, deep adenomyosis. This study can't be done because it was not ethical and nobody can do it. And in our 1,000 study, of course, we will focus on the ability of microRNA to focus on especially adenomyosis patient for whom surgery was performed and hysterectomy was performed in order to know in this subset of patients if we can design and found few microRNA, especially associated with the adenomyosis phenotype. For the moment, I can't give you any information about that, but this is a really, really clever question, and I hope I will be able to answer soon with good data.
Engin Oral asked if you could explain the difference between the test from .lab from the United States, from the Yale group, which has been published some years ago. So what is the difference in your work
I
to
found,
that test?
thank you, and Harald, to this question. I found three differences. First one, the publication from Mustafa, which came from in AJOG, say we focused on 6 microRNA to design the diagnosis of endometriosis. Of course, we used those 6 microRNA and we applied those 6 microRNA to our population, and we demonstrated that those microRNA are not enough accurate because the number is low. This is the first difference. Second, we focused on the saliva and they focused on the blood. And for the moment, nobody focused on the saliva, and nobody focused on the saliva, especially on endometriosis. And third, actually, the microRNA signature for endometriosis, this is the most accurate tools to diagnose endometriosis. And in my opinion, because I read very carefully the publication from Mustafa, which is a really brilliant publication, because we have lots of information and lots of clever information. For the moment, we have many differences between the two approaches.
Thank you. I wonder if we treat endometriosis by hormonal treatment or surgery, and we do the test again, will it be then negative?
I can, what I can say. We have to expect the publication of the 1000 study in the first trimester of next year, and we will present the result, I hope, in the FIGO Congress in October in Paris. But this question is really, really, really important. I don't know who asked me the question, but this is really a brilliant question.
Yeah, I think this is very important, because this would give us a tool to follow up the treatment that we do, because this is also an open point. It's not just the first diagnosis, but it's also the ongoing pathway of our patients' lives, and how to follow up on these patients and the results, and if they have a reception of the hormonal treatment or not. So mainly now we are just focused on symptoms, which is very important too, and this will always be important. But if we could measure what we are doing, of course, this would be much better.
You said everything. This is true. And for the oncologist people around the table, you know that, for example, we have now some idea about the microRNA evolution after treatment, for example, after chemotherapy and after other treatment. And if we expect the same result in endometriosis, probably we could expect from the microRNA to answer to all these issues. I totally agree with you.
Could you also imagine that we might learn in the near future that in this patient we need to be more radical, and in another patient not so radical, like we now treat endometrial cancer, for example? I mean, this is what we currently do. We can measure the molecular profile, and we know which patients will have a problem and which patients will have a good result.
This is wonderful to understand those questions, because you understand everything. As a surgeon, my main issue is how to select the good patient for surgery. And because I made lots of surgery, I know sometimes it was not the good moment or the good patient, because we have some inflammation, and behind the surgery, the results are not enough and are not expected as I want, as the patient want. That's why we have to focus on the disease, the phenotype of the disease, and to understand what happened behind the symptom. For the moment, we are all focused on the symptom, which is really important for the patient, but we have to be more precise and more accurate at the biological point of view and at the biological level.
There's a question from Professor Miller from Bern, from Switzerland, and I will read it. You mentioned that half of the patients in the 200 study had severe endometriosis. Usually a good history of the patient, clinical examination, and a good sonography is sufficient to diagnose endometriosis in these patients. What is the sensitivity, specificity of the test in ARSAM 1 and 2?
Thank you for this question, Professor Müller. First of all, I'm happy to understand that sonography is enough to diagnose endometriosis, but probably when you have a good radiologist, or if you are a good sonographist, this is probably true. But when you said that, you have to understand that the patient and all publications say, okay, we are all the best surgeon, we are all the best sonographists, we are all the best radiologists, but the people wait 7 or 10 years. And this is a fact. And after that, okay, what we can do to improve this? Second, you asked me the issue of the endo test for the early stage. And this issue is very clear for us because we have now a publication which is very close to be published when we focused especially on those early stage. What is early stage patient? This is patient with peritoneal endometriosis lesion and women compared to women with endometriosis symptoma, but without endometriosis after laparoscopy and pathological analysis. And when we analyze the signature specifically and especially for this population of early stage, we have the same result as it can be published. To answer to your question, sensitivity and specificity for early stage is the same than the publication first of all was reported.
There's another interesting question about adolescents. I think it's a special group, and at what age can we start to use the test, or should we use the test?
For the moment, we perform study only on women over than 18 and before to 43 years old. This is what we published. We are launching a study focusing on teenage women in few next day. And we hope to have a result in this specific population of women about the accuracy of the test and the accuracy of those microRNA for young women, because this population is really important in practice.
Yeah, thank you. There's another comment from Amit Namazov from Israel, and he wonders about the role of laparoscopy and the test. So if we say that a negative biopsy or a negative histology from a biopsy does not exclude endo, and I absolutely agree on that. He says that the same can happen by the test, but yeah, again, where is the place for the test? I think you already answered that question, but maybe we can clarify this point.
Yeah, if the test is made to improve the delay and to improve the non-invasivity of surgery to make the diagnosis. And if you, of course, I am surgeon, of course, I used to perform laparoscopy to diagnose patient. And of course, this is an easy way to make the diagnosis, but it is not because it is an easy way, then we have to perform it always. And for me, the test have, because of the accuracy of the sensitivity and the specificity, will replace surgery for patient with symptoms suggestive of endometriosis. And after that, if you want to continue to perform laparoscopy to make the diagnosis, as you want, it is the same way of thinking with sonography. It is a way of thinking with MRI.
Yes, I also think that it's absolutely positive, and as we are involved in the treatment of gynecological cancer, and we now see the development in this area and how fast things develop, and everything is changing, and this goes to the same direction. So I think it's very important to be open-minded and to include new perspectives to our vision of the future. But of course, now I think it's up to us to explain this to our patients, to the gynecologists, and everybody has to understand the role of new possibilities. So I think this is something that needs a lot of intervention now, because the situation is quite unclear. You know, we know now much more than 1 hour ago, but I think there's still some necessity for more information, and this is important for patient support groups. It's important for us as a society to give the information of the role of the test, how it works, and how it can be included to diagnostic approach.
And if I can just add something, Harald, and I totally agree with you, and thank you really for your support. We will launch a few studies in the next days, or in the next months, and because we have oncology surgeon and gynecologists from everywhere, if you want to be included as a center in our next study, it will be we will be very happy to have you with us in the next step of our work and of our clinical trials.
Great. I think this is interesting for many of us. So are there any more questions? I cannot see any new questions on the chat. So I think we discussed this topic in detail. Once again, thank you very much for your time and for your presentation. It was very interesting for us to learn about the test and the science behind it. And I think there will come new things very soon. And it will be great to see if we can also measure results, phenotypes, and so on. So thank you very much. Many greetings to Paris, and a good night to everybody. And thank you for joining tonight. Thank you so much. Good evening.